So I think the major highlight of the GU ASCO Symposium, in my opinion, is the CheckMate 274 trial. This was a randomized phase III trial that evaluated Nivolumab, a PD-1 inhibitor, compared with placebo therapy given for a year in patients with high-risk muscle-invasive urothelial carcinoma. So these are patients who had received neoadjuvant or preoperative cisplatin-based chemotherapy and had muscle-invasive disease or higher stage at the time of radical cystectomy or nephroureterectomy. Or there were patients who were cisplatin ineligible, who had not received neoadjuvant chemotherapy of any sort, had radical cystectomy or nephroureterectomy, and had extravesical disease, T3 or higher disease on surgery. So in these patients, Nivolumab compared with placebo for a year improved the co-primary endpoints of disease-free survival in the overall population, as well as in the PD-L1 high tumor patient population. So these were the co-primary endpoints that were agreed upon in this study, based upon the fact that disease-free survival is a reasonable surrogate for overall survival in these patients. The hazard ratio was robust. When you look at all comers, the median disease-free survival improved from 10.9 months for placebo to 21.0 months for Nivolumab. Hazard ratio was 0.70. In those with tumor PD-L1 1% or higher, which was the defined PD-L1 high population, the median disease-free survival was not reached in the Nivolumab population and was the same, similar 10.8 months in the placebo population. This hazard ratio was even more robust at 0.53. Now, overall survival admittedly was not presented. However, the study has met its co-primary endpoints. I believe, based upon these data, that Nivolumab, at least in the PD-L1 high population, should be considered a practice. This data should be considered as practice changing. And of course, we await to see what the FDA says about this. We also want to see what the survival looks like. We, of course, also want to see a trial that's ongoing, the Ambassador trial, that's looking at adjuvant Pembrolizumab. And this is not compared with placebo, but observation and surveillance. We await that. In the backdrop, of course, is the IMvigor010 trial, which looked at adjuvant Atezolizumab, which was presented at ASCO 2020. And this trial was negative, and which is why the results of this CheckMate 274 trial were somewhat pleasantly surprising. Now, one of the interesting other data sets that has emerged is the retrospective analysis of IMvigor010, which looked at the benefit from Atezolizumab based on circulating tumor DNA, ctDNA, post-op. So post-op ctDNA informed by tumor genomics, where they looked at a platform called the Natera platform by Natera, which is looking at the ctDNA presence in the post-operative setting. And suffice it to say that in this retrospective analysis presented at the ESMO IO meeting in December 2020, patients who were ctDNA positive for minimal residual disease post-op appeared to benefit from Atezolizumab, which is an exciting finding because it suggests that we could potentially select the best patients for adjuvant therapy and spare the rest, a drug which could have potential toxicities, of course. So I think that these data need to be looked at more in detail as the data matures, as the publications come out. And so all of these represent, I think, exciting advance in the field of urothelial carcinoma. I'd like to highlight a study called the RETAIN BLADDER study, which was conducted by the Fox Chase Cancer Center in Philadelphia. This is a somewhat novel strategy to treat muscle-invasive bladder cancer. As we know, the background is that neoadjuvant cisplatin-based chemotherapy, followed by radical cystectomy, is the standard of care in these patients. So what this study did is did genomic profiling of the tumor tissue of patients, and they selected a handful of DNA damage repair mutations that would confer a DNA damage repair defect. And we know that historically, patients who have these somatic alterations have a higher probability of achieving pathologic complete remission with neoadjuvant cisplatin-based chemotherapy. So the question to ask would be, and is what was asked in this study, was in patients with these genomic alterations who achieve a clinical complete remission, i.e. no tumor on cystoscopy after neoadjuvant chemotherapy, could these patients be spared from radical cystectomy and go with the active surveillance strategy? So this was done in these patients. It was a small study. The overall size of the study was 71 patients, and approximately half of them entered this active surveillance group that had the DNA damage repair mutation and achieved a clinical remission. And suffice it to say that this strategy is interesting. It seems feasible. One thing to remember is that these patients who were surveilled did have a recurrence rate of around 65%. But of these recurrences, about half of them were non-muscle invasive, and the other half were a higher stage. One thing to remember is most patients did well. The overall outcomes looked reasonable, and you could spare these patients a radical cystectomy. However, there were a couple of patients who did have a metastatic recurrence on the surveillance strategy. So this strategy still needs to be validated and studied some more, and at this time would not be considered a standard of care, but it is nevertheless an interesting strategy. So I wanted to highlight a second study that was in the non-muscle invasive bladder cancer space, which looked at a drug called N803, which is an interleukin-15 or IL-15 superagonist. So this study was a non-randomized study which looked at patients with non-muscle invasive bladder cancer who had BCG unresponsive disease, and delivered to these patients the combination of BCG again with N803, both delivered intravesically. So this was again a small study. It was a non-randomized study, but in approximately 70 patients, the investigators did achieve a complete remission rate that was somewhat impressive at 71%. And also at 1 year out, 56% of patients maintained a complete remission. The duration of complete remission was also quite impressive at 19.2 months. So as we know, in this space, Pembrolizumab is approved for BCG unresponsive disease. And of course, this is Pembrolizumab given intravenously, not intravesically. And the Pembrolizumab approval was based on a 40.5% complete response rate with a median duration of complete response of 16.2 months. So just comparing across studies, these data with the N803 plus BCG look impressive. So we await some more data to accumulate from this study, and we wonder if this could be available in the clinic at some point. But these are promising data for N803 in combination with BCG for non-muscle invasive bladder cancer with carcinoma in situ.